Common complications of hemophilia A include long-term joint problems that may require joint replacement, bleeding in the brain, intracerebral hemorrhage, thrombosis due to treatment. Let's look at thrombophilia now, which is kind of the opposite of hemophilia. Disorder in the body's ability to maintain the smooth flow of blood through the venous and arterial system. Concentration of particular elements in the blood creates clogging or blockage issues. General term for conditions that result in blood clotting more easily than normal. It can be inherited, genetic disorder, medications, or other factors, or it can be a cancer patient. Clots can spontaneously develop in the blood of the patient, right? And they are at risk for what we call DVT, deep vein thrombosis. Common medical problem in sedentary patients and in patients who have had recent injury or surgery, right? These patients are at a high risk for pulmonary embolism because if that clot dislodge, it can cause a PE. You may encounter several methods to prevent blood clot formation, including blood thinning medications, compression stockings, mechanical devices. Risk factors include recent history of joint replacement, and the patient complains of swelling in the legs. Travelers, so people doing long distance traveling that not moving the toes or the legs around. A patient that is bedridden in a nursing home or old age home. Treatment, anticoagulation therapy. Medications are typically administered for at least 3 months after diagnosis for a DVT. Patients prescribed medications to treat DVT are at an increased risk of bleeding complications. A clot from the DVT can travel from the patient's lower extremity to the lung, causing a pulmonary embolus. Pulmonary emboli can cause chest pain, difficulty breathing, and sudden cardiac arrest. I'm going to go through the patient assessment for this section. Going straight to the emergency medical care for hematologic disorders. Mainly, so the care is going to be mainly supportive and symptomatic. Patients with inadequate breathing or altered mental status, you will administer high flow oxygen at 12 to 15 liters per minute via non-rebreathing mask. Place the patient in a position of comfort, transport rapidly to the hospital. That's it for diabetic and hematologic emergencies. Let's go to the next chapter. Chapter 20. All right, so we're going into chapter 20. This is immunologic emergencies, and most of what is in this chapter you should already know if you covered shock extensively, right? So if you covered shock extensively and you've been covering respiratory emergencies extensively, a lot of what is in this chapter you already know, right? So let's get into it. All right, now EMTs often respond to calls involving allergic reactions, right? And once it's a serious allergic reaction, we are concerned that the airway can be compromised, and we are concerned that the cardiovascular system can be compromised, right? So the patient can have a severe airway problem, and they can have distributive shock because the blood vessels are too dilated. You must be able to treat these life-threatening complications, distinguish between the body's usual response to an allergen and an allergic reaction. Immunology is the study of the body's immune system. Anatomy and physiology. The immune system protects the body from foreign substances and organisms. When a foreign substance invades the body goes on alert. The body then initiates a series of responses to inactivate the invader, and this will ultimately lead to what we call an allergic reaction. An allergic reaction is an exaggerated immune response to any substance, not caused directly by an outside stimulus, caused by the body's immune system. So the body releases chemicals to combat the stimulus. These chemicals include histamine and leukotrienes or leukotrienes. Right? When these chemicals are produced systemically, causes issues with the airway, causes the blood vessels to become too dilated and too permeable. Some patients may not know what is causing their reaction, so you must recognize the signs and symptoms, and you must maintain a high index of suspicion. An allergic reaction may be mild or local, right? If it's mild or local, that's not something for us to worry about. We can use antihistamine to deal with that. If it is severe and systemic, then we have an airway problem and we have a cardiovascular problem. That's anaphylactic shock or anaphylaxis. Anaphylaxis is an extreme, life-threatening allergic reaction, and it involves multiple organ systems, and it can rapidly result in shock and death. So it can affect the lungs, the heart, the blood vessels, the skin. And that chart shows you the complications. 3 common signs of anaphylaxis, right? So there are 3 common signs of anaphylaxis. These are what we would call cardinal signs. Urticaria or hives is 1, angioedema is 2, and wheezing would be 3. So these are the 3 common signs of anaphylaxis. Urticaria or hives, angioedema, which basically the tongue starts to swell up or facial swelling, and wheezing. So urticaria, hives, small areas of generalized itching or burning that appear as multiple small raised areas on the skin. That's urticaria. Angioedema, areas of localized swelling, so facial swelling, the tongue can swell up, and there's a particular blood pressure medication that can cause this. What is that medication again? ACE inhibitors, right? So ACE inhibitors can cause serious angioedema. So angioedema, areas of localized swelling, wheezing, high-pitched whistling, breath on expiration. All right, you may also note low blood pressure, right? So hypertension due to vasodilation and increased capillary permeability. They can have gastrointestinal dysfunction, which would include nausea, vomiting, abdominal pain, or cramps. All right, so let's look at common allergens. So you have food, may take more than 30 minutes to appear. Shellfish, nuts, right? So Those are some common ones. Medication, antibiotics, example, penicillin, non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, aspirin. If medication is injected, the reaction may be immediate and severe. Reactions to oral medications may take more than 30 minutes to appear, but can also be very severe. All right, now with the plants, you have your dust, your pollens, and other plant materials, ragweed, ryegrass, maple, and oak. With chemicals, makeup, soap, hair dye, latex of particular concern for healthcare providers. So most services in the States stop using the latex gloves. You tend to use the nitrile gloves more now because of allergy issues. Insect bites and stings. When an insect bites and injects the bite with its venom, this is called envenomation. The reaction may be localized, swelling and itchiness, or it can be systemic where the entire body is involved. Insect stings, approximately 3% of adults and 1% of children are allergic to venom of bees, wasps, and hornets. Allergic reactions to insect stings causes at least 50 deaths per year in the United States. It's not, these type of reactions are not common. So in Jamaica, we don't get a lot of allergic reactions from bee stings. That's not common here. The stinging organ of most insects is a small hollow spine projecting from the abdomen. Venom can be injected directly into the skin. And I'm hoping at this point we know the ways that allergens can enter: inhalation, injection, ingestion, absorption. The honeybees cannot withdraw their stinger, fly away, and die after they sting you. Wasps and hornets can sting multiple times. Some ants, especially the fire ants, strike repeatedly, inject a particularly irritating toxin at the bite site. Signs and symptoms that you will be looking for: sudden pain, swelling, localized heat, urticaria, redness in light-skinned individuals, itching, and a wail. Applying ice sometimes helps. Swelling may be dramatic and frightening. Localized manifestations are not serious. What we're really worried about is if they are developing anaphylactic shock or anaphylactic reaction. That's what we're really worried about. In severe anaphylactic cases, patients may experience bronchospasm and wheezing, chest tightness and coughing, difficulty breathing, anxiety, gastrointestinal complaints, low blood pressure. This is a patient that will require epi. Patients may occasionally experience respiratory failure. They start to feel means they have poor ventilation. So you now need to be prepared to breathe for this patient. If untreated, anaphylactic reaction can proceed rapidly to death. All right, so the patient assessment. Conduct your scene size up. Ensure that your scene is safe. The patient's environment or recent activity may indicate the source of the reaction: sting or bite, food, allergy, new medication regimen. These are things you need to consider. Be mindful of other potential causes of respiratory distress. Traumatic injury may also be present. Follow standard precautions with a minimum of gloves and eye protection. Consider the need for additional resources, such as advanced life support personnel. Once it is available, request ALS. In your primary, quickly identify and treat any immediate or potential life threats. Form a general impression. They present as respiratory or cardiovascular distress in the form of shock. Patients often appear very anxious. Call for ALS backup if available. Look for medical identification tag, right? Assess upper and lower airway. So anaphylaxis can cause rapid swelling of the upper airway. You have only a few minutes to assess airway and provide life-saving measures. Work quickly to determine the severity of the symptoms. Quickly assess for increased work of breathing, use of accessory muscles, head bobbing, tripod positioning, nostril flaring, abnormal breath sounds. And you may, if you have epi within your protocol and you're seeing obvious signs of anaphylaxis, even before you have ascertained this from the history taking, you may have to give that epi before getting a full history to correct the breathing problem. Assist the patient. Yes, Miss Nesbitt.
What if it's like one of those things that are in the patient's, like probably thigh, like you see the insect thing? At what point do we remove it? Do we remove it in the primary assessment or when we see? Can you clarify that, please?
You would remove it once you see it. So that can be done in your primary assessment. That can be done in the primary. Right? And you can do it in circulation. Right. Now, assist the patient into high Fowler's position to maximize ventilation. If signs of shock, place the patient in supine position. Do not hesitate to initiate high flow oxygen. In severe situations, assist using bag valve mask attached to oxygen. All right. Circulation may present with hypotension. Palpate for the presence and quality of a radial pulse. Assess for rapid pulse rate, cool, cyanotic, or red moist skin, delayed capillary refill. May indicate hypoperfusion. So, in other words, look for the signs of shock. Treatment. Oxygen, positioning, recumbent or supine, prevent the loss of body heat. Definitive treatment for anaphylactic shock is epinephrine, right? So once it's anaphylaxis, epinephrine is what the patient needs. Transport decision, always provide prompt transport for any patient who may be having an allergic reaction along the patient's medication. If the patient does not exhibit severe symptoms, consider continuing the assessment or on the side of emergency transport. If you're not sure, transport rapidly. History taking. Investigate the chief complaint, history of the present illness. Identify associated symptoms. And there's a nice chart that you can spend some time and look at, right? Where it outlines the signs and symptoms per system, right? So respiratory system, cardiovascular, skin, and others. Pay attention to that chart, table 20-1. Sample history. If possible, ask the following questions. Have any interventions already been completed? Has the patient experienced a severe allergic reaction in the past? If they did, this reaction might be even worse. Be alert for any statements regarding ingestion of foods that cause allergic reaction. Ask about gastrointestinal complaints, which would include nausea and vomiting. A secondary assessment, physical examination includes systemic head-to-toe or focus assessment. Auscultate for abnormal breath sounds, wheezing, or stridor. Now, I would be listening for breath sounds in my primary. I would want to be doing that now. I would want to be re-evaluating breath sounds in my secondary, but I would encourage you to listen to breath sounds from early. Inspect the skin for swelling, rashes, or urticaria. Assess baseline vital signs, pulse, respiratory rate, blood pressure, pupillary response, oxygen saturation. Skin signs may be unreliable. Monitoring device, pulse oximetry can be a useful method to assess the patient's perfusion status. It can help you to make decisions around management for airway, work of breathing, and what you need to do if you hear any abnormal lung sounds. Reassessment. Repeat primary assessment, reassess the patient. Vital signs, repeat focus physical exam. If the patient is unstable, reassess every 5 minutes. If stable, every 15. Deterioration of patient's condition could be rapid and fatal. Monitor the patient's anxiety level, mental status, watch for signs of shock. Interventions. Determine the severity of the reaction. Mild reactions require supportive care and monitoring. Anaphylaxis requires epinephrine and ventilatory support. Transport to a medical facility, recheck interventions. Communication, documentation. Documentation should include signs and symptoms, reason why you chose to provide the care you did, patient response to the treatment. Now let's look specifically at emergency medical care for immunologic emergencies. If the patient appears to be having a severe allergic or anaphylactic reaction, administer BLS, provide prompt transport to the hospital. That's it. If a stinger is present, scrape the skin with the edge of a sharp, stiff object such as a credit card. So don't use anything like a tweezer to pull it out. Use something like a credit card to remove it. Wash the area with soap or antiseptic solution. Remove any jewelry from the area. Position the injection site below the heart. Apply ice or cold packs. Ice or cold packs. Be alert for signs of airway swelling. Always be looking out for that, right? Always pay attention to the airway. Be alert for signs of airway swelling and other signs of anaphylaxis. Place the patient in a supine position. Give oxygen as needed. Monitor the vital signs. Your drug of choice is going to be epi, right? So if you suspect anaphylaxis after you have done your primary assessment and you have managed any live threats that are present and your history has been completed, you should be considering giving epi And ideally, you want to get a full set of vital signs. That might not be possible depending on how severe the reaction is, but ideally you want to. Right? But this is a drug of choice to reverse anaphylaxis. Patient may have the medication in the form of an EpiPen, or it may be on your unit in the form of a solution where you have to draw it up and give it via syringe. The ambulance services don't carry the EpiPen on the ambulance anymore. It's too expensive. So you're gonna find it in either a vial or an ampule on the unit. Epinephrine mimics the sympathetic fight or flight response. So it causes the blood vessels to constrict, and that reverses the vasodilation and hypertension, and it increases cardiac contractility and relieves bronchospasm. So it opens up the ear passage, right? So it's correcting both issues that are the primary problems with anaphylactic reaction. So it's perfect. Now you may have to give it more than once, so keep that in mind. And there are some patients where the EpiPen has 2 doses, not 1. Epinephrine is prescribed by a physician and comes pre-dosed in an epinephrine injector, EpiPen. Your EMS service may or may not allow you to assist patient in administration of epinephrine. So you will be guided by protocol and medical direction. All kits should contain a prepared auto-injectable syringe of epinephrine. Adult epi is 0.3, which would be minimum, to 0.5, which would be maximum milligrams IM. For infant, it can be 0.01 milligram per kilogram or 0.15 milligram to 0.3 milligram. Side effects of epinephrine: high blood pressure. So it's going to cause the blood pressure to go up. Increased pulse rate, anxiety, can also cause cardiac arrhythmias, pallor, dizziness, chest pain, headache, nausea, vomiting. These are the side effects. Do not give epinephrine to patients with signs of respiratory compromise or hypotension. Those who do not meet the criteria for diagnosis of anaphylaxis, right? And that would take us to the end of this chapter. Not a long chapter, very short, right? So that's immunologic emergencies. What time is it? It's 10:41. Let's look at chapter 18. See how far we can get in this one. All right. So gastrointestinal and neurologic emergencies would be next. That's chapter 18. All right, I think I might. All right, so let's save this one for, we'll save this chapter for next week. I'll try and cover that next week. Let's keep it at 2 chapters for today. All right, so let's go back to drug calculation. And zoom in on your end. What am I doing? Zoom in if you need to. And so if you need to, zoom in on your end. So we had started to go through the drug formulas, and we had looked at exact concentration, right? The exact concentration is the amount of drug divided by the available volume, right? So it's the weight of the drug divided by the amount of fluid. And exact concentration is how much of the drug is available in 1 ml. And we had gone through some examples, and I had covered the percentage. We were at the percentage. And I had said to you that whatever value the percentage is, it represents the amount of grams in 100 fluid, 100 mils of fluid, right? So if it's 5%, it's 5 grams in 100 mils. If it's 10%, it's 10 grams in 100 mils. And you just follow the formula. Now, let's go over to the next page. Am I seeing this correctly? All right, so example 4, 10% solution in milligrams is 10 grams in 1,000. Sorry, 10 grams times 1,000. Right, this is where we were at. Now, the question can ask you to give it in a specific measurement, right? So the 10% represents 10 grams in 100 mils, but we need the exact concentration in milligrams. So the first phase of the problem solving would be you write out what the 10% represent. So we need to convert the 10 grams into milligrams. And to do that, we have to multiply it by 1,000, because we're moving from a large measurement to a small one. So when you're moving from a large measurement to a small measurement, you multiply by 1,000, right? And when you go in the other direction, you divide. So 10% solution is the same as 10 grams in 100 mils. But to convert the 10 grams to milligrams, we multiply by 1,000. That would give you 10,000 milligrams divided by 100 mils, or 10,000 milligrams in 100 mils. What would be the exact concentration? So that's 10,000 milligrams divided by 100 mils, which would give you 100 milligrams per mil. That's the answer. Classwork, and I want you to type the answer. What is the exact concentration of a 20% solution in grams and milligrams? So I want the exact concentration in gram and milligram. Work that out, type your answer. Work it out, type the answer. It shouldn't be taking that long. Work it out, type the answer. I'm waiting on the others to type answer. What are we doing so long? Where are the answers? I've only seen one response. Miss Johnson, are you present?
Lockdown.
Okay. Miss Jackson, are you present? Miss Jackson, are you present? All right, so moving right along. 0.2 grams per mil would be the exact concentration in grams, and 200 milligrams per mil would be the exact concentration in milligrams, right? So it's 20%. That's the same as 20 grams in 100 mils. So it's 20 divided by 100. If we want to convert it to milligrams, whatever you got when you divided 20 by 100, you simply multiply that by 1,000. All right, now you may have a medication in a solution form, sorry, in a ratio form, right? Like epi is in 1:1. You have 1:1. You have 1 in 1,000. You have 1 in 10,000 for epi, right? So 1 in 1,000 would be the epi that you give for anaphylaxis. 1 in 10,000 is the epi that we give for cardiac arrest. All right, so what it really means, if you see a solution with a ratio like 2 in 1,000, it's the same as 2 milligrams in 1,000 microliter, which is the same as 2 milligrams per mil. Right? So 2 in 1,000 is 2 milligrams in 1,000 microliter, or it is the same as 2 milligrams per mil. Right? And if you see a solution that is 2 in 10,000, which is the same as 1 in 10,000 epi, that is the same as 2 milligrams in 10,000 microliter, which is the same as 2 milligrams in 10 mils. And the exact concentration of that would be 0.2 milligrams per mil. So that's 2 milligrams divided by 10 mils. Classwork. You have a solution in a ratio form, 3 in 1,000 and 3 in 10,000. What is the exact concentration for both? Do that quickly, type the answer. Okay, yes, so that is correct. Miss Jenny, Miss Nesbeth and Mr. Jennings, that's correct. You're still having a block, Miss Johnson?
Yes, sir.
That's something that you will have to work on, you know. So you need to catch me on a day that is convenient for both of us, because the next assignment that you guys are going to get is a drug calculation assignment, and it will be the second half of your pharmacology grade. So we're gonna have to work on that. All right. Now, where am I? Good. All right, so the next formula we are going to look at. So I'm finished with exact concentration. I think I've sent the drug formula via email. I would suggest that you go and look at it again. Ask questions. Don't wait until it is not convenient to do so. Right? So if you don't ask questions, I can't make things clear. And I think I've sent this over a week now. All right, so the next formula is volume of a drug to be given. Right? So we need to be able to work out how to give the desired dose from the available concentration that we have. Right? So let's say you have a concentration of 10 milligrams in 5 mils. We need to, and the desired dose is 2 milligrams. Right? So we have a concentration of 10 milligrams in 5 mils, but the desired dose is 2 milligrams. We need to know how much mils we will draw out of that solution to give us the 2 milligrams, right? And to do that, we use this formula. So it is the volume of drug to be given, right? That is the desired dose, that's the dose that you are supposed to give, times the available volume, that's the amount of fluid, divided by the amount of drug you have, right? So desired dose, what you are supposed to give, times the volume or fluid available, and the amount of drug that is in that fluid. So example 1, give 2 milligram of 8 milligrams in 4 mils. So you have a 8 milligram in 4 mil solution, and you need to give 2 milligrams. So that the desired dose would be 2 milligrams. The available volume or fluid would be 4 mils. And the amount of drug would be 8 milligrams. So it is 2 milligrams times 4 mils divided by 8 milligrams. So we would draw up 1 mil. So 1 mil would represent 2 milligrams. The second example, example 2, give 2 milligrams of a 10 milligram in 2 mil solution, right? So we need to give 2 milligrams of a 10 milligram in 2 mil solution. The desired dose is 2 milligrams. That's the desired dose, the dose that we are supposed to give. The available volume or fluid is 2 mils. The amount of drug present in that volume is 10 milligrams. So based on our formula, desired dose times available volume divided by the amount of drug we have, that would be 2 milligrams times 2 mils divided by 10 milligrams. And that would give us 0.4 mils. So 0.4 mils is what we would pull from that solution. All right. Now, classwork. You are required to give 100 milligrams of a 250 milligram in 5 ml solution. Work that out. What would be the volume of drug to be given? Your desired dose is 100 milligrams. The available volume is 5 mils. The amount of drug you have is 250 milligrams. What would be the available? The drug volume required. All right, let's see what's going on here. Yes, that would be correct, Mr. Jennings and Miss Nesbitt. So it would be 2 mils. So that's 100 milligrams times 5 mils divided by 250 milligrams. That would be 2 mils. So that would be correct. All right. All right. All right. So I won't go into volume of fluid to be given today. Do I need to? All right. We can do that next class. All right. So I won't go into volume of fluid. We'll just look at volume of drug to be given. We'll look at the volume of fluid to be given. And once we have completed that, I will send your drug assignment. Matter of fact, I might very well send it from now. The drug calculation assignment. All right. So we will save that one. Let me stop sharing this for a sec.